This is a painting of one of my patients at the moment when he was diagnosed prostate cancer with metastasis. It takes him away from his usual life, from his family, from his wife, and he was captured in the pawns of this monster. Just that we should keep that in mind when we are talking about treatments, that there is a whole landscape of suffering in these patients. Diagnosis of new metastatic prostate cancer, that's what I am talking today, is increasing. Here's some data in the US and of Europe. And historically, prostate cancer is an androgen-sensitive disease. That it means if you take away the testosterone, then the tumor decreases. Any problems? Okay. So prostate cancer is a hormone-dependent disease, and the target of therapy is the androgen receptor. And this is from the Nobel Prize lecture, where Huggins was talking about his experience with new androgen deprivation treatment. And even at that time point, he said that despite tumor regressions of great magnitude, it's obvious that there are many failures of hormone therapy to control the disease. And probably this answered the question which was put before. So we are looking for other treatments, because at the start of diagnosis, there are androgen positive and androgen negative cells. From the very beginning, the tumor will finally progress. And this is a 47-year-old patient, and he died 17 years later due to metastatic castration-resistant prostate cancer. And the genetic analysis showed that the lethal clone arose from a small fossils present at diagnosis. And if you look at the data concerning prognosis, overall survival, in those patients who are only treated with hormone therapy, the median overall survival is 42 months. That's not much. That's not what we want. And if you look at the green line, the time where you have any event as a sign of progression is only 11 months. So are we targeting this tumor heterogeneity, which I was talking, in the right way? Probably this is another field which opens now. We want to have some kind of subtyping, of subclassification of prostate cancer, as we know from other solid tumors, as like from breast cancer. And there is probably one which is classifying prostate cancer into luminal A, luminal B, and basal cell types based on a kind of molecular subtyping. And you see, if you have a luminal B tumor after surgery and you give androgen deprivation therapy, you see it in the upper graph, then the patient lives longer. But if you have a non-luminal B tumor and you give hormone treatment after radical prostatectomy, then the patient lives shorter in comparison to if you give no therapy. So just think of that. That's the problem we have always been talking about. Probably that's a solution. Data in prospective studies will come, I'm sure. And that are the data which brought us to combine therapy if we have a patient with metastatic prostate cancer. 2 animal models in rat and in mouse showing that if you combine chemotherapy with hormone therapy, then you have better results. And these are the 2 landmark studies which show the largest survival benefit of any medical treatment in prostate cancer ever. CHART-IT and STAMPEDE trial. And if you have patients with castration-naive prostate cancer, castration-naive prostate cancer means no hormone therapy, no therapy until that time, you have a survival benefit of 13 months if you have a high volume disease. That's a bit of discussion taking place. What is high volume? What is low volume? We have no definitions of that. Most are saying that if you have 4 metastases in the bone and at least 1 is outside the pelvis and the spine, like in the femur, for example, or if you have a visceral met, like lung and liver metastasis, that's high volume. But we have no definition, no studies on this definition. And you've heard that lung metastasis probably may occur very early as we think, and may stay without progression, probably as a kind of feeders for further metastasization. And the other one is the STAMPEDE trial, the largest trial in metastatic prostate cancer, showing even a survival benefit of 22 months, comparing the combined treatment with chemotherapy and hormone treatment in comparison with hormone treatment alone. So that's the new standard. That's why I'm talking about that if you have a high volume disease, probably treatment works better. And low volume is not working that much, but we have no predefined good study for low volume patients, and we have to do this to say that low volume patients probably do not respond that much than high volume patients. And these are the new European guidelines for patients with prostate cancer with metastasis who haven't had any treatment. Androgen deprivation therapy, that is castration, medical or surgical, in combination with docetaxel, the chemotherapy. But what is heavily discussed, especially also by the oncologists, should we give all patients this treatment or only those who had high volume? That is under discussion. I give it to all my patients. At least you have to offer it, because the survival benefit is much, much higher than with any other treatments after the patients are not responding to castration treatment anymore. So this is a kind of schedule what we have until now. And you see in the red circle, docetaxel plus androgen deprivation therapy. That's the first treatment we have, and all the other treatments are coming afterwards, and you will have a talk on that later. And if you look at the survival benefit, you immediately see what I mean. You have a survival benefit of 10 and 15 months in the large studies in the castration naive setting. But if the patients get resistant to hormone treatment and then you use chemotherapy or other treatments, then you have only a survival benefit of about a median of 3-4 months. So you lose efficacy of your drug, and you will get the drug anyway. So are we targeting tumor heterogeneity in the right way? Are there other drugs? Should we move all drugs in the early setting or in an earlier setting in metastatic disease in combination with hormone treatment? And there's abiraterone, a testosterone synthesis inhibitor. So you see that from cholesterol, due to some enzymes, you get testosterone, and you can block that, and you can block that with abiraterone. And that was a drug which was designed very early in the 90s by a really good chemist. And then De Bono, an oncologist, was seeing and recognizing the potential of this drug. Then we had early phase trials, and then we had phase 3 trials in castration-resistant prostate cancer, which showed a survival benefit of about 3 to 5 months. But in the castration-resistant setting, so the patients had hormone treatment and didn't respond to hormone treatment anymore. Probably if you start very early with this testosterone biosynthesis inhibitor, you block also the production of other localizations, like from the prostate cancer cells or like from the adrenal glands. And this may help to prolong survival in this setting. And this is the design of one of the 2 studies which was previously presented in the ASCO, in the American Oncology Congress last week, the Latitude study. And you see androgen deprivation therapy alone in green was compared to androgen deprivation plus this testosterone synthesis inhibitor, abiraterone. And you see that they had also some kind of subclassification in a high volume or high risk one. And if 2 or 3 risk factors were met, then the patients were included. And that were visceral mets, so lung or liver mets, more than 2 bone mets, or Gleason's score 8. And these are the results. there was a statistically significant reduction of death of 38%. And you see that the survival time with androgen deprivation therapy plus placebo is 34 months, but it's not even reached in the group with androgen deprivation therapy, so castration plus the testosterone synthesis inhibitor abiraterone. And the overall survival rate at 3 years was 66% with the drug, the combination, and 49% with only androgen deprivation with placebo. That's really a lot. That's a dramatic result. And this result was also completely confirmed by the other study which was presented at the ESCO, the Stampede trial. And also all the other things. The patients are interested not only in living longer, but they want quality of life. They don't want any pain medication as long as possible. And they don't want any problems with broken fractures because of the tumor. And all these things were prolonged with this treatment. So now we have two combinations in the setting when you are diagnosed metastatic prostate cancer. Docetaxel plus androgen deprivation treatment and androgen deprivation treatment plus abiraterone. But which to use first? What are the perspectives of combination therapy? The benefit obtained from adding abiraterone to androgen deprivation therapy appears to be the same as that seen with chemotherapy with docetaxel. Both showed the same results, nearly completely the same results, though they were acting through completely different mechanisms. The use of abiraterone may avoid chemotherapy, so probably you give chemotherapy later. Or if you start with abiraterone, you give chemotherapy later. It avoids complications of chemotherapy with fever and loss of leukocytes, but these side effects are rare, 5%. Androgen deprivation therapy plus abiraterone, which is a tablet, by the way, replaces short-term intravenous treatment by long-term oral treatment. So either chemotherapy for 4.5 months or 3 years oral treatment. Probably the combination of androgen deprivation therapy with abiraterone is more appropriate for elderly patients or those who are not fit for chemotherapy. But there are other problems. What is about financial toxicity? This drug, abiraterone, costs about 3,000 to 4,000 euro a month. So it was given for 33 months. So that's a lot of money. Should we treat even earlier? And that we had the discussion before. So patients had a PSA progression, a PSA rise, and we find no metastasis. Should we treat earlier? Because if we do a PSMA PET, you've heard before, a better examination, we find the metastasis earlier. So it doesn't matter. Should we treat earlier? Or should we, and I think that's probably some really tempting stuff, should we combine abiraterone with docetaxel and androgen deprivation therapy in castration-naive prostate cancer? So do we have some additional effect? We don't know. Thank you very much.